Welcome back to our third segment of this panel, and this is our final set. Our first speaker is Dr. Jessica Lee, and Dr. Lee is with the Center for Medicaid and CHIP Services within the Centers for Medicare and Medicaid Services. Dr. Lee.
Thank you so much. I am honored today to talk about Medicaid and CHIP. But first, I wanted to pass along one update about Medicare before we dig into the Medicaid and CHIP activities I'm really excited to talk about. I wanted to talk about one policy that came out recently and that many of you may have already known about. But in the spirit of level setting, I always believe in making sure that everyone starts with the right information. I also want to give a shout out to my colleague, Dr. Michelle Schreiber, who sits on PACHA and helped me with this update. So CMS proposed a national coverage determination that would make PrEP for HIV a Medicare Part B preventive service, which means that it would be available at no cost to beneficiaries who qualify. In addition to PrEP drugs, this proposal included coverage of up to 7 counseling visits per year, additional HIV screenings, and screening for hepatitis B. Currently, oral antiretrovirals used for PrEP are covered by Medicare Part D, but again, this proposed national coverage determination would eliminate the beneficiary cost sharing for all of these services by providing coverage under Part B. CMS has published a fact sheet to share information with pharmacies to help them with Medicare enrollment and to prepare for future coverage of PrEP for HIV under Part B. So I wanted to start with just that brief update before we really dig into my topic today, which is talking about recent regulatory updates to improve access to care for people insured by Medicaid and CHIP. And this is a broad topic, but the reason why is this. So Medicaid and the Children's Health Insurance Program, or CHIP, are the largest healthcare payer in the country with more than 83 million people enrolled. This includes more than 265,000 people living with HIV, or 40% of the population of people living with HIV. Both programs are federal and state partnerships, meaning that the states administer the programs within these broad federal guidelines. Today, I'm going to be talking about recent policy updates supporting our goal of improving access to high quality care. Policies that directly address many of the known gaps in care for people living with HIV, many of the gaps that we've heard about this very day. So I'm excited to be talking about some of our recent regulatory updates and the way that they will improve care for people living with HIV. So, talking first about our access strategy. So Medicaid and CHIP, as I mentioned, provide essential health care, and beneficiaries access their healthcare services using both managed care and fee-for-service delivery systems. Previous regulations addressing access were not entirely comprehensive or consistent across payment systems and programs. Addressing those issues required a thorough programmatic review and a coordinated strategy with the following goals: to remove barriers for eligible people when enrolling in and maintaining coverage, and to ensure equitable access to Medicaid covered healthcare services and supports. You're going to see this everywhere, that advancing equity is a cornerstone of all of our policies. We plan to achieve these goals through 3 rules, which we've released all in the last few months. The first is our eligibility and enrollment rule, released in March. And then the next 2 were the ensuring access to Medicaid services, released in April, and our managed care final rule, also released in April. So talking briefly about our enrollment and eligibility rules. So, these changes I want to highlight build on key lessons from our ongoing work with states as they continue conducting Medicaid and CHIP renewals. This is making critical changes that will improve how individuals both receive and maintain their coverage. These improvements are especially critical given that backdrop of unwinding. Medicaid and CHIP renewals, as you likely know, restarted last spring following the end of the pandemic era Medicaid continuous enrollment requirements. And we've learned a lot of lessons from that. We found, for example, that strategies to simplify renewals and encourage retention, such as giving people more time to turn in their paperwork, led to more eligible people maintaining coverage in states that took up these options. So the rule makes changes along these lines to streamline application enrollment processes, improve retention rates at and between renewals, remove access barriers for children, and to enhance program integrity. Going back to that kind of giving people more time to turn in paperwork, for example, one of the requirements is it requires states to provide individuals with a certain amount of time to provide additional information when applying for the first time and a longer amount of time when they're renewing their coverage. Looking now to the other two rules that I mentioned, as I mentioned, we released two final rules in April, both of which have really important implications for people who are living with HIV who are enrolled in our programs. Our priority has been to help people stay covered, whether in Medicaid, CHIP, or other options. And I also just want to take a second to say that we're grateful to everyone at this conference and all the other viewers, all of our partners who have helped to support those efforts during the unwinding process. We released these two rules, which advance access to care, quality of care, and will improve health outcomes for Medicaid beneficiaries across both the fee-for-service and managed care delivery systems, including the home and community-based services provided through these delivery systems. These improvements seek to increase transparency and accountability, standardize data and monitoring, and create opportunities for states to promote active beneficiary engagement in their Medicaid programs with the goal of improving holistic access to care. Oh, one. I can't go back, so we're just going to go with this one. Okay, recognizing that, oh, here we go. All right, recognizing that managed care is the predominant delivery system in Medicaid and CHIP, with over 80% of Medicaid and CHIP beneficiaries receiving some or all of their care through a managed care plan. The managed care rule specifically helps to build stronger managed care programs that better meet the needs of people enrolled by improving both access and quality to care. Going through just a few elements of this that I think really highlight why it's so important in terms of the population of people living with HIV. Some elements of the managed care rule include establishing national maximum standards for certain appointment wait times. That's the first ever national maximum standards. And as well as stronger state monitoring and reporting requirements related to access and network adequacy, requiring states to conduct independent secret shopper surveys of Medicaid and CHIP managed care plans to assess compliance with the appointment wait times and to identify inaccuracies in provider directories, creating new payment transparency requirements for states by requiring disclosure of provider payment rates in fee-for-service and a comparison to Medicare rates for certain services. Establishing additional transparency and interested party engagement requirements for setting Medicaid payment rates in the home and community services space, as well as a requirement in terms of how much of these payments have to be spent on compensation for direct care workers. Other elements to highlight are that these rules create timeliness of access measures for home and community-based services, strengthening these necessary safeguards to ensure beneficiary health and welfare. It also strengthens how states are using state Medicaid advisory committees. This is really something I want to highlight because this is the mechanism by which various interested parties can advise Medicaid agencies about health and medical care services, ensuring that all states are using these committees to more optimally realize a more effective and efficient program that's informed by the experiences of Medicaid beneficiaries. So this is one place that that people can get involved in their states in terms of having a voice on these Medicaid advisory committees and the beneficiary advisory committees. Other elements include requiring states to conduct enrollee and experience surveys, and establishing a framework for states to implement a new Medicaid and CHIP quality rating system, which will be a one-stop shop for enrollees to compare Medicaid and CHIP managed care plans, empowering enrollees to be able to select the plan that's best for them. So I want to turn now to briefly talk about some updates addressing quality, noting that I could actually talk for a lot longer than 12 minutes, but we're going to try to hit some highlights in 12 minutes because I won't. So quality, this is an area to really highlight in terms of federal collaboration, both within our own agency and also with partners like CDC and HRSA. Quality measures are critical to understanding how a system is working to deliver integrated whole person care in a complex and often fragmented environment. The Medicaid and CHIP child and adult core sets measure the overall national quality of care for beneficiaries and provide state-level data to drive improvements in healthcare and advance equity. These data and measures help us to understand how we're doing, where we're doing well, and where we need to improve. The HIV viral load suppression measure is an excellent example of a measure that achieves these goals, representing multiple facets of healthcare delivery, in addition to collaboration at both the level of the patient and at the state level. Core set measures are reported publicly when 25 or more states report them. And while we've not yet reached that threshold for the HIV viral load suppression measure, we're seeing higher numbers every year with the support of a HRSA-funded learning collaborative that's been helping states build capacity among HIV surveillance and Medicaid programs for reporting high-quality viral load suppression data for the Medicaid core set. I'm going to talk briefly about updates and policies related to addressing health-related social needs. You've heard some themes here in terms of our emphasis on improving our ability to bring people to care and care to people wherever they are. That's been reflected in the work we've done to expand things like school-based services, access to community mental health and substance use crisis care, and new opportunities to improve transitions for incarcerated individuals who are eligible for Medicaid by allowing coverage for healthcare services during the period prior to release. I want to emphasize one other opportunity in terms of meeting people where they are, and that's that CMS developed a place of service code supporting street medicine. This place of service code can be adopted by payers to help drive innovation and to ensure access for individuals for whom this is the best place to receive care. To date, this code has been used by primary care and behavioral health professionals serving populations experiencing homelessness, and has also been adopted by payers, including Medicaid programs in Pennsylvania and Hawaii. These are some of the programs that really are policies that combine innovation with common sense, supporting that core goal of connecting people with evidence-based interventions. And in the case of health-related social needs, partnering with housing and social service agencies to improve access. So we've issued a number of new policies addressing health-related social needs, which we define as an individual's unmet adverse social conditions that contribute to poor health. These needs, such as food insecurity, housing instability, which we've talked about multiple times today, unemployment, lack of reliable transportation, we know they can drive health disparities across demographic groups, and we know that they have a profound impact on the health of individuals. So we've done a number of different things to try to support states in addressing health-related social needs. States can address health-related social needs through a variety of different Medicaid authorities, including state plan authorities, Section 1915 home and community-based services waivers, state plan programs, managed care authorities, Section 1115 demonstrations, which I'm going to talk more about, as well as CHIP health service initiatives. So a lot of different opportunities. I want to highlight that the housing and nutrition supports that are provided under the home and community-based services authorities have served as a critical precedent for helping individuals stay connected to coverage and needed care, and connecting people to the additional services needed to meet their comprehensive health needs. There's also some really important precedents in prior 1115 demonstrations, such as those in North Carolina and Massachusetts. So in December of 2022, we announced a new Section 1115 demonstration opportunity to support states in addressing health-related social needs. These are opportunities for states to pursue demonstrations, pilots, experiments that are expected to promote the interests of the Medicaid program. As of May, 8 states have taken up our new opportunity, in addition to states that include North Carolina that had prior demonstrations in this area. In January of last year, we also published guidance that describes the innovative ways that states can use authorities in Medicaid managed care to address health-related social needs. And then in November of last year, we published an informational bulletin and a framework of services and supports that we consider allowable. These are all easily found on Medicaid.gov, or if you search Medicaid's space HRSN, you'll find these. I think one thing to highlight in terms of the framework is that we define what all of these things are. So thinking about the alphabet soup of the federal government, we define what each of these authorities are, who's covered in each of them, really trying to make our programming accessible to new partners. One thing to discuss briefly just in the 1115 demonstrations, and I do promise I'm wrapping up, the 1115 demonstrations have gotten a lot of attention, which we are very excited about in addition to our state partners. So we think about this under 4 elements. The first is covered services, which we talked about briefly. Our framework includes housing and nutrition supports in addition to case management. I want to highlight that other services, including transportation, may be allowable as well, but we dealt with them outside of this specific framework. Transportation, I also want to note, we issued a Medicaid transportation coverage guide in the fall of last year, outlining all the different ways that states have to assure that Medicaid beneficiaries who have no other means of transportation have transportation to covered healthcare services. So transportation is a really important topic in Medicaid, and we've done a lot of work in this area. Looking at the service delivery column for Section 1115 demonstrations and health-related social needs, the services have to be medically appropriate, determined using the clinical and social risk factors that the states define. They have to be the choice of the beneficiary who can opt out at any time. So they cannot be required or disqualify the beneficiary from any other services. And then this one is really important. They must be integrated with existing social services. We are not reinventing the wheel. We are not becoming experts in some of these areas. We are asking our states, and in fact requiring our states, to partner with housing and social service agencies to make sure that we're building on decades of experience and working with trusted community partners. There are important fiscal policies around these Section 1115 demonstrations, which include things like the expenditures can't exceed 3% of a state's total demonstration spend, and some specificity around budget neutrality requirements that I'm not going to get into for these purposes. But one thing to note is that, state spending on related social services before the 1115 must be maintained or increased. This reflects that our services are intended to complement but not replace the existing social and housing services. Again, going back to that integration. And then finally, two important related requirements. The first is that state Medicaid reimbursement rates for primary care, behavioral health, and OBGYN must meet certain thresholds where the state has to commit to increasing them. This reflects that connections to care can only be successful if there's access to timely care, if there are providers there to provide that care on the other side. And then finally, we have systematic monitoring and robust evaluation requirements that are really going to help us understand how these are working at states and learn to improve in the future. So before I turn it over to my colleagues, I want to outline a really important area of collaboration. It actually is pure chance, I understand, that that I'm on with HUD and ACL, who are the people I talk to, like maybe some weeks. But anyway, they're critical partners in the HUD and HHS Housing and Services Partnership Accelerator, which also includes agencies such as SAMHSA, which is a critical partner, HRSA, critical partner, all of them are critical partners. I borrowed this slide from ACL, however, so thank you. Yeah, you see the logo on the bottom, so thanks ACL. The Housing and Services Partnership Accelerator is an opportunity for us to support states that are working to accelerate and develop innovative state strategies to provide housing-related activities and services to persons with disabilities and or older adults who are experiencing or at risk of experiencing homelessness. We are supporting 8 states plus the District of Columbia in the Housing and Services Partnership Accelerator. At the end of this month, we have our in-person meeting with them to work through things. And these are states that are bringing their Medicaid and housing partners to the table to figure out how to get this done, because the federal policy is really only step A, and the magic happens in all the other steps as this actually gets implemented. So we've been incredibly grateful for the partnership across departments to actually make this happen. I can't say more than that. And also want to note that the 3 states speaking at the panel tomorrow all have are all states that are in our partnership accelerator. So with that, I will turn it back over. Thank you.
Thank you so much, Dr. Lee. Our next panelist is going to be joining us virtually, and that is Rita Harcrow, who serves as Director of the Office of HIV and AIDS Housing at HUD. Turn it over to you, Rita.
Thank you. Thank you. I hope everyone can hear me. I wish I was there in person. Great to see you all. And thank you, Jessica, for talking about the accelerator, also a very exciting project for us at HUD. As we just mentioned, I'm Rita Harcrow. I use she, her pronouns. I'm the Director of the Office of HIV/AIDS Housing at HUD, and I'll focus briefly on the HOPWA program and how that program has worked to align with EHE. Next slide, please. First, I want to start with a reminder that research shows that housing status is a social determinant of health that has a significant impact on HIV care outcomes. Stable housing provides a foundation from which people can participate in other aspects of HIV care and services. A very basic overview of the HOPWA program. HOPWA was established in 1992, and it's still the only federal program dedicated to addressing the housing needs of people with HIV. HOPWA grants are made to eligible cities, states, and nonprofit organizations. And the program provides housing assistance and supportive services to low-income people with HIV and their families. There's HOPWA programs in every state, all 50 states, DC, Puerto Rico, and the U.S. Virgin Islands. The HOPWA program was appropriated at $505 million in 2024. And the 2025 president's budget is also $505 million for HOPWA. Next slide. Although the HOPWA funding has increased each year over the past 7 years, it's not enough to assist all people who qualify for HOPWA and need assistance. By statute, HOPWA can only assist people living with HIV and their families. So with that in mind, in 2021, 45,770 households received housing assistance under the HOPWA program, and that's things like rental assistance, short and long-term assistance, facility-based, that kind of assistance. However, my office estimates the number of low-income people living with HIV in the U.S. that are eligible for HOPWA and not getting it. We estimate that number is between 328,000 and 415,000. So there's a real difference in the amount of folks who are eligible for HOPWA and those that are actually receiving housing assistance. In the HOPWA EMSA grantees that include an EHE jurisdiction, so the HOPWA EMSA might cover multiple counties and have one county that is an EHE jurisdiction. We estimate 252,000 plus individuals were eligible for HOPWA and did not receive it in 2021. That's the latest data we had available. And of those 252,000 individuals, we estimate that about 20,430 experienced homelessness at some point in the 12 months before the data was collected. So we estimate that over 20,000 people with HIV in EHE jurisdictions experienced homelessness at some point in the prior year. As a reminder, HUD currently does not receive funding specifically to participate or support EHE efforts. And also as a reminder, when we talk about people who are eligible for HOPWA not receiving it, we don't have data on other programs that might be supporting those households. Because other HUD programs do not require an HIV diagnosis. So that's a data point that is not collected by HUD for other programs outside of HOPWA. I know that's a lot of data in one slide, so you'll have this slide later. Next slide, please. So without EHE funding, HUD seeks to support EHE in other ways. Through planning and through our HOPWA competitive funding. And here you see we have the two last NOFOs, or Notice of Funding Opportunity, that have been open. Prior to the 2020 NOFO, the last NOFO happened in 2015, which was the VAWA HOPWA program. So there was 5 years in between. Now with the increase that we've seen in HOPWA funding, we hope to move toward an every other year competitive NOFO. So the 20 HEFA, or Housing as an Intervention to Fight AIDS, HEFA grants were awarded in December 2021. Those are 3-year grants with a max of $2.25 million per grant. And the purpose of HEFA grants is to provide communities with opportunities to create and implement new projects that align with ending the HIV epidemic initiatives and to elevate housing as an effective structural intervention in ending the epidemic. The 20 selected applicants received a one-time 3-year grant to fund housing assistance and supportive services for eligible beneficiaries, coordination and planning activities, grant administration, and management. And then the HOPWA HINT, or Housing Interventions, NOFO, builds off of that HEFA grant NOFO, and we hope that we'll be able to announce HINT grantees later in June, so stay tuned for that. Next slide, please. This is just a closer look at the HINT grantees. I'm sorry, these are the HEFA grantees. Note that 16 out of 20 HEFA grantees are providing housing and services in an EHG priority jurisdiction. So it's every grantee except those that are in Missouri, Hawaii, and Colorado. And the HEFA grants cover a wide range of geographic locations across the U.S. with projects that are located in rural areas, suburbs, and cities. Next slide. HEFA grantees are just now finishing up their year 2, so we're pending year 2 data, but just sharing some initial results and comments. Grantees in their application can identify a target population or subpopulation in their application process. And some examples of what were approved include Black transgender women at Chicago House, youth age 18 to 30, AIDS Foundation of Chicago focused on that, as well as homelessness, and people aged 55 and older. The Damien Center has that subpopulation in their HEFA grant. So Chicago House is integrating medical, housing, and employment services by having all team members meeting with the client together and being very intentional that services are integrated for the client. And that drives the message that all services are equally important. In Chicago, the AIDS Foundation of Chicago was also able to restart and take the lead of the Housing Committee under the Getting to Zero Illinois plan. The Housing Committee is meeting monthly, and it includes representatives from all 8 regions of the state, plus Illinois Department of Health, with the goal of using housing as a tool to end the HIV epidemic in Illinois. One thing I want to point out is for the HOPWA SPINS grants, we are requiring data collection through an HIV housing care continuum form, and this is enhanced data collection reporting from our normal HOPWA reporting. The enhanced reporting uses CDC-defined data elements for the HIV care continuum. And as those grants progress, we anticipate sharing richer data related to HOPWA and health outcomes along the continuum. Next slide, please. And finally, I wanted to share a collaborative effort between HUD and HHS, and it's the Supporting Replication of Housing Interventions, or the SURE program. The SURE Housing Initiative is a Ryan-White Part F SPINS funded project, and it supports people with HIV experiencing unstable housing among 3 priority subpopulations who often have the highest HIV-related disparities, and those include LGBTQ+, youth and young adults age 18 to 24, and people who are involved with the legal system. The SURE Housing Initiative leverages Ryan-White funding with other local resources that include HOPWA and other HUD programs. And HOPWA grantees had the opportunity to apply for funding to participate and use their HIV housing expertise and leverage in the initiative. And the goal of the SURE Housing Initiative is to promote the replication of rapid rehousing in the Ryan-White program to decrease health and housing disparities and improve health outcomes. The core components of rapid rehousing include housing navigation for clients to secure a lease in their own name, housing stability case management to connect clients to resources that help them maintain their housing. And we have identified the 10 organizations across the U.S. Who are participating in those. And again, more outcomes to come from that soon. And last slide, please. I just want to thank you for the opportunity to present and share some links here for more information about how HUD is working within the HOPWA program locally. And I will turn the presentation back over to Andrea Callow. Thank you all.
And our third panelist is Andrea Callow, and she is with the Administration for Community Living and is a senior advisor for HIV policy.
All right, there we go. Thank you so much. Again, I'm Andrea Callow with the Administration for Community Living, and so pleased to be here. I recognize I am the last speaker of the last panel. I thank you for your endurance. Yeah, a first day, right. So For those of you who might not be familiar with us or who just want a refresher, ACL, Administration for Community Living, really our bread and butter is older adults and people with disabilities. So we administer programs to support our populations. And those programs include the Older Americans Act, which is sort of the 600-pound gorilla of aging services, but also uh, DD Act services, Developmental Disability Act services, independent living services for people with disabilities. We have 11 authorizing statutes, so sort of a whole range of programs. We also develop national policies and priorities to improve the well-being and independence of older adults and people with disabilities. And importantly, we serve a leadership and advocacy role. So we advise the Secretary of the Department of Health and Human Services, other operating agencies in HHS and across the federal government on all things aging and disability. So I think it's particularly topical today on Long-Term Survivors Awareness Day to discuss the programs that we have engaged in on behalf of older adults. I think we all probably know the stats. Over half of people living today with HIV are over the age of 50. That's going to go up to 70% by 2030. And in response, ACL has really pretty rapidly scaled up its work on HIV. And we've really had the great fortune of working in collaboration with colleagues across the department, many in this room. You guys have sort of put your hands out to us and we've grabbed it and tried to quickly learn the landscape of HIV services so that we could be effective in our work on behalf of older adults living with HIV. So I'm going to touch on a few of those initiatives and partnerships, not an exhaustive list, but hopefully some that are of particular relevance to the discussion today. So first, a little bit about work we've done with the HRSA HIV/AIDS Bureau on Ryan White services and Ryan White recipients. When I started doing this work, I think one of the first reports I read was about the silos that existed between the HIV services network and the aging services network. They weren't coordinating, they weren't talking to each other, they didn't even know how to find each other really. So one of the first things we did is to begin work with a particular aging group within HRSA-HAB and figure out how we could do some really targeted education around breaking down those silos, getting them talking to one another. And, you know, I think like one of the coolest things about the Ryan White statute and the Older Americans Act statute is this opportunity for public engagement, not just sort of in a check the box way, but really in the way that the services are planned and delivered. There is this mandate that the public needs to get involved. And so the idea was that Ryan White participants could be a resource to Older Americans Act state units on aging who are doing that state level planning, and then vice versa, that the Aging Services Network could be a resource to Ryan White recipients. So that involved, for example, having a training from HRSA-HAB at the convening of state units on aging. Again, those state bodies that do the Older Americans Act planning. This is what Ryan White is. This is where you can find them. This is where it's important. So that hopefully as they put together those multi-year blueprints that they are required to give to us to receive our money at the federal level, they're going to call their Part B or their Part A and say, hey, where are the gaps? What should we be doing? You guys are the experts. And again, start to break down those silos. And the reverse was true. We had a training for the Part B recipients on Older Americans Act state planning and how they could get involved. So I think that's really exciting. It's particularly exciting now because we updated our Older Americans Act regulations for the first time in over 30 years. It came out on Valentine's Day of this year. And so we, in those regulations, designated people living with HIV as a population in greatest social need. And so what that means is everyone receiving Older Americans Act money needs to show us how they're going to focus service delivery on people with HIV. And as I said, you know, these silos have existed. The aging network may feel ill-equipped to meet the needs of people aging with HIV, and we believe that what Ryan White recipients can be, again, an excellent resource. They are experts, and that the community itself can be an excellent resource as our recipients look to come into compliance and ramp up their efforts to do outreach and engagement and service delivery for older adults living with HIV. So again, I think that's just getting started. We're at the education level. The regulations just came out. They're just being implemented. But it's an exciting opportunity for that kind of collaboration and cross-pollination to really get essentially like the most bang for our buck too. Leverage each other's resources, each other's knowledge, and make sure that we're doing things right and that we close these gaps, and also that we don't replicate. So that's going on right now. And then finally, funding and lifting up promising models. And another shout out to the AIDS Foundation of Chicago. They are really like knocking it out of the park. We are currently funding them for a training curriculum for for Ryan White case managers devoted to HIV and aging. It's right now in beta testing. I got an email from them yesterday. We're eagerly looking forward to that curriculum to see how it works for all of those Chicagoland Ryan White case managers. We also, if folks remember, it's a lot of fun, had a challenge with OIDP, the HIV and Aging Challenge, where we announced winners. Folks got a pot of $75,000 to pilot projects on HIV and aging. We're hoping to, not hoping to, we will exhibit some of those winners at the Ryan White Conference in August, see what they're doing in their communities. Teaser, it's great. It's really great. It's really exciting. It's really innovative. It's exactly what we wanted it to be. So stay tuned. Next slide. So Commit to Connect. I love talking about Commit to Connect because it's a great program. So as again, this is not news to us, especially in the wake of COVID. Social isolation is a public health crisis. It's an epidemic. It's particularly harmful for older adults, and we know it occurs for older adults with HIV at a very high rate. When you sort of poll older adults with HIV, or at least the informal polls I've seen, like, you know, it ranks very high up there as a concern. So to address this growing public health crisis, ACL, with support from OASH, thank you, OASH, created this cross-sector initiative that is coordinated by US Aging. US Aging is the trade organization for the area agencies on aging. They're the local hubs to administer Older Americans Act programs. So this really does have a great focus for older Americans. And its goal is to reach folks who are socially isolated to help alleviate that. And it does this a couple of different ways. It builds a nationwide network of champions to collaborate on solutions to reach people. There's an online clearinghouse that matches people who may feel lonely or socially isolated with customized strategies and resources to help them connect and engage. It establishes critical partnerships and shares successful initiatives that can be implemented in communities across the country. We have an advisory council of 20 leading organizations in aging and disability, AARP Foundation, Meals on Wheels America, National Indian Council on Aging, that just a few. We also are guided by a scientific advisory council because this is a public health epidemic. We want to be led by the science. And within the federal government, we work closely with the Office of the Surgeon General and the CDC to run a social connection coordination interagency team. That's a mouthful. 90 members, 37 offices and agencies for a cross-sector collaboration. This actually was presented to the Federal AIDS Policy Partnership Aging Subcommittee recently. It was warmly welcomed, and we had a lot of uptake in our national network of champions from people living with HIV, leaders in the HIV community. So I'm very happy that the community really, really ran with this. That's what we wanted. That's what we want. And finally, 3 programs I just want to highlight briefly because I think they are of particular relevance, as I said, to folks aging with HIV. The State Health Insurance Assistance Partnership, or SHIP, the Senior Medicare Patrol, SMP, and the Long-Term Care Ombudsman, the Ombudsman. So again, major concern that we hear from older adults aging with HIV, they're coming into Medicare and they're completely baffled and afraid of losing access to their medications, to the provider they've been with for a long time. And, I don't know anyone aging into Medicare who's not overwhelmed, confused, and afraid. I've tried to help parents and friends, and even I am confused and overwhelmed and afraid. So the SHIP program is a national one-on-one counseling, assistance, and education program for Medicare beneficiaries and the folks that try to help Medicare beneficiaries. And importantly, it's objective. It is financed by the federal government. It is not sponsored by a private Medicare Advantage plan or a Part D plan or any other insurance plan. And SHIP counselors are in every community. Many of them are volunteers, and they're there to help people make decisions to retain access to their health care and to smoothly, enroll in Medicare without making some of those mistakes that can really have lasting financial and health consequences. So we work closely with CMS. We have a formal MOU in place with CMS, and when SHIP sort of starts to bubble up systemic issues, we have our Office for Health Insurance Counseling and ACL that can kind of look at those and contact CMS and say, hey, we're seeing this all over the country, what's going on? So Senior Medicare Patrol is focused on Medicare fraud. And it's interesting, Medicare fraud really has a substantial impact on Medicare beneficiaries. If someone is submitting a Medicare claim in your name, you're getting the 20% coinsurance, and that can be a lot of money. Also, it's illegal, and it is not good for, the federal fisc. We are opposed to fraud. So Senior Medicare Patrol collaborates with state and federal partners, including the Inspector General, CMS, Medicaid fraud control units, DOJ, states attorneys general, to combat Medicare fraud. And it also employs Medicare beneficiaries and older adults as volunteers to root out Medicare fraud. And finally, the Long-Term Care Ombudsman, another high concern we hear on from older adults, folks aging with HIV, is I don't want to go into a long-term care facility. I am afraid of discrimination. I am afraid of poor quality of care. They don't know, they don't understand HIV. They are going to treat me poorly. Essentially, I will be forced to go back into the closet, these sorts of things. The Long-Term Care Ombudsman is a resource to all residents of long-term care facilities, including people with HIV, obviously, and they identify, investigate, and resolve complaints from residents. They provide information, not just to residents, but to staff as well. And they are around. They are in the long-term care facilities on regular visits, on unannounced visits. They represent the interests of residents between governmental agencies and administrative hearings. For example, if a resident, let's say, is being discharged and wants to contest it, an ombudsman can help represent them. And they also perform a systems advocacy role, which I think is really important. They comment on, like, say, changes in state law and regulation pertaining to the health, safety, and welfare of long-term care facility residents. So they're advocates. They're advocates at the individual level, and they're advocates at the systemic level. So I think that's all I have to go over today. I'm happy to take questions. There's my email address, or talk more about what ACL is doing on HIV and aging. Thank you so much for the opportunity.
Thank you so much, Andrea. Well, if we go over, we'll blame it on our co-chairs. We'll take questions from Marlene, followed by Vincent. Thanks.
I just want to quickly say thank you to Andrea. I know the HIV space reached out to you, but thank you for reaching back and really engaging and sharing in these exciting new ways. And so I look forward to more and continued engagement from you. I really have more of a comment and a request for Dr. Lee. We've spent most of the day really combing through the data and talking about inequities and where we still see persistent challenges and stalemates as it relates to seeing reductions and unfortunately dramatic increases in terms of transmission and acquisition of HIV in key communities. I really want to talk about how we still have a persistent issue, and it's related within the umbrella of CMS. And I know there's lots that you cannot comment on as it relates to enforcement issues, but I do want to continue to raise the issue and put it on the radar at CMS about challenges that we have within the state of Texas. I know that there's been lots of work and advocacy with the Consumer Information and Insurance Oversight Center around enforcement of policies and protocols that are being implemented by private insurers who are operating on the health insurance marketplace. One in particular who has shifted away from covering single tablet regimens. It's been several years now that this issue has persisted. And the idea that they are forcing folks onto outdated formularies, those treatment regimens that are more toxic and less efficacious. And so we are hoping from the community space that there is continued research and involvement and engagement with what's going on with coverage levels, particularly for people living with HIV, particularly in states who have not expanded Medicaid, particularly in those areas that continue to see persistent high rates of HIV and health disparities of all kinds. So I'd be remiss not to mention that every time we have the fortunate opportunity to have CMS at the table, because we long for it. We know that this partnership will need to be a close and tight-knit partnership for a long time. So I just wanted to raise that to your awareness, Dr. Lee, and hopefully that, we have an opportunity to continue that dialogue.
Absolutely. So, just start by saying thank you for, the attention that you're bringing to our programming in terms of the opportunities for us to improve the way that care is delivered to individuals who are living with HIV. There are some aspects of the specific comment that I can't address specifically, but I can both take back a lot of it and also just reflect that we're looking at the same data that has been reviewed today. We look at all this data, we look at it very carefully, and it drives a lot of decisions that we make. So, you heard me talk about, I kind of went one by one in terms of making it easier to get coverage, making sure that people have access to appointments, tightening up oversight and accountability standards around Medicaid and CHIP, both in the managed care space and the fee-for-service space, and then kind of moving into person-centered care, both in terms of just, physically bringing care to people, but also addressing some of the other things that we've talked about today in terms of, for example, housing insecurity. So, we're looking at exactly the same data that you are, and we're thinking very carefully about the opportunities that we have to make new policies and to enforce the existing policies to support care, and appreciate ongoing feedback from you and the rest of the community.
Casey.
So sorry to gang up on you, but Dr. Lee, I do have a question. So, based on, all of the panelists that have presented the different data today, there is very obviously a correlation and an overlap of the states that do not opt in for 1115 and 1915 funding. And those are the areas where we have these higher incidence and prevalence rates that are continuing. So my question for you, obviously you have no control over what states do and do not opt into, But are there other have there been discussion of other potential funding opportunities so that in those states, organizations can then apply for like NOFOs or anything like that to try to address all of the issues that that expansion is covering?
No, I totally hear you. And, every state approaches their program differently. And we're committed to working with every state that wants to improve the delivery of care. I think just to kind of look at the broad landscape, one, we've had a lot of attention on Section 1115 demonstrations, but a lot of states, and just to put it out there, states that you might not have expected have actually used not only those Section 1915 waivers or state plan amendments. I think that's one thing to keep in mind is that there's two different mechanisms in there, and managed care authorities. These are new opportunities in lieu of services that states can take up in different ways. And so, while we don't make decisions for our state partners, what we can do is remove barriers in terms of trying to do innovation through all of these different things, and then try to make it as clear and easy as possible. And that's actually why we put out the framework that we published in the fall. For people who've tried to publish a giant federal chart, getting that through government clearance is not the easiest thing to do. But we published a giant federal chart because we wanted to make it as easy as possible for states to take up these innovation opportunities and for states to have as many options as possible in terms of the authorities that they could use.
Vincent.
Thank you very much. So first, I'm going to just say thank you to the panel. Forgive me, but my question is also for Dr. Lee. So Dr. Lee, I apologize in advance for that.
I'm never coming back. No.
So I don't necessarily agree with this sentiment, but I wanted to raise something that I've been hearing and just sort of see if I could get your perspective on it. There's a lot of excitement about these demonstration projects that specifically integrate health-related social needs into Medicaid dollars. But I think I've been hearing increasingly some critics, and I want to share some of what I've been hearing and just get a sense of your thoughts. And so one thing that I've heard is that the science of how these projects, the evidence for how these projects are going to work and achieve the outcomes that they're intended to achieve is not that clear, and that it's not well specified that we understand that we'll get to a clinical outcome with the integration of these two elements, the health-related social needs and then also traditional care. That there's a risk that there's a reallocation of dollars that are being put into sort of health delivery through Medicaid that otherwise would be in the social welfare system, and that social welfare having a broader mission beyond health. And is that something that we should be concerned about? I think there's a tension around social determinants of health, and then a distinction between health-related social needs. And are we really hitting the mark? And then I would say, lastly, I hear folks arguing that a lot of the emphasis has been on cost containment and not on sort of clinical outcomes. And are we seeing clinical outcomes? I know, for example, we have Secretary Kingsley tomorrow. I know that North Carolina did see a sort of reduction in per person cost in their preliminary data, but have we seen clinical outcomes and improvements? And again, I don't necessarily agree with this. I'm a big advocate for exactly what you guys are doing, but I wanted it to be part of the discussion.
No, absolutely. I have to say, you should always listen to criticism just as loudly as you listen to praise, maybe more so, to actually be open and think about what you're doing. So a few different things. We listed a number of different potentially approvable interventions. And when we listed those interventions, we actually went through and looked at evidence, the evidence base for each one. If you look at the Social Determinants of Health playbook that was published by the White House in the fall, that's been really helpful in terms of providing an evidence base. And then, the next step from that is in terms of taking something that has an evidence base and trying it in the population for Medicaid. But not just throwing it out there, really rigorously evaluating it and also being extremely thoughtful in terms of the implementation. So states are working really hard on their implementation protocols and then the actual rollout of these services to make them the most likely to work. And then we're looking really carefully at this, both with things like interim evaluation requirements and ongoing systematic monitoring of a lot of different kinds of levels. To get at the health outcomes part, as part of that, there's a lot of different ways to look at these. some of the things we're going to be looking at is things like getting connected to benefits like WIC and SNAP. So if you're eligible for WIC and SNAP, getting connected to those benefits. We're also going to be looking at whether or not these services resolve the person's housing or food insecurity, for example. So, in terms of that, we're going to be looking at healthcare utilization, like you mentioned before, and we're also going to be looking at health outcomes. I think one of the tricky things with this area of intervention is that the time horizon for the effect on health can be quite long. For some things, they can be quite short. And we've seen that in a lot of different studies. But there is a robust amount of evidence to support how important these services are. I want to tackle I think there's two more parts. The first is tension between social determinants of health-related social needs. I would actually posit that there's not a tension. There are two different actual levels of definitions. And frankly, it's good to level set in terms of these terms. We're using that term really specifically in terms of how it relates to health. And that's related to the Medicaid mission and our role in the healthcare system. And then finally, in terms of replacing other social services, for the 1115s, we have a really specific requirement that states have to maintain or increase their spending on related social services. Compared to before the 1115. And that's to reflect that we are not replacing the existing social services infrastructure, which, as you noted, have really important jobs that extends beyond the direct connection to health. And so, we are listening to these criticisms too, because, we're thinking about ways to implement our program and to make sure that we are protecting the integrity of the Medicaid program while we're also seeking to support innovation in whole person care.
So, yep. Tori? You all finished playing with those cards?
Wow. So my question for you is also, but it's specifically about the HOPWA program.
I'm going to defer that one to Rita if
Okay,
she's still
perfect.
on.
Rita Harcrow.
Hi, yes, I'm here and I could not hear the first part of your question. Sorry.
Well, I haven't asked it yet,
Oh, okay.
but it's good to see you.
Okay.
So my question was, if there are 45,000 people who were served in 2022, and yet almost 400,000 could have been eligible, why is there such a huge gap in the number of people who are accessing the program? Housing is HIV care, we know that. And if people are missing out on an essential service, that's not just people who are experiencing homelessness, but also people who are experiencing challenges to paying their rents or through, I think the program is Strom U, which helps people who pay their mortgages for people who are living with HIV. What is it can't just be red tape, or is it?
It's actually funding based. So many of our HOPWA programs do have wait lists, and they have to cap their levels of support just based on the amount of money that they're receiving locally. So it comes down to, those local budgeting decisions and helping as many people as they can with what's available.
And understanding we can't take too much time, but what is one way to, I don't know what the correct term, how to say it correctly, but how do we get more people involved in the program that doesn't come at the expense of people who are already in the program?
Again, I think it's increasing the level of funding available in those communities. We do work with communities through technical assistance on how to leverage other funding. But if you look at the HOPWA budget compared to some of the other HIV programs represented today, you'll see it's much smaller. And the money has to be spread around, fairly thin in some communities. So there's just not resources available to serve all the need. And I think you might be talking about the tenant-based rental assistance program where people have been on the HOPWA TIBR program maybe for years, because that is a permanent program. And we don't encourage people to be removed from that, but we do have some moving on strategies where we can work with communities through technical assistance on helping people move into other mainstream kinds of housing, like Section 8 or other vouchers, other facilities that are not specific to HIV, while continuing to receive HOPWA supportive services. So we are able to do some things like that locally. Unfortunately, some of the other resources are also strapped. So, it really becomes just a matter of trying to maximize the resources that are there.
Jesse, and I think that was the last placard.
Thank you. Thank you all. This has been also very, very instructive. I've learned a lot. But Andrea, thank you so much. We're so glad to have ACL at the table at PACHA. Thank you, thank you, thank you. I feel like you've been circling around with a bag of things that we needed to know, and now we know them. Can this SHIP program be easily adapted at perhaps minimal cost, but I think we need your feedback, because Alicia Diggs and I, as the co-chairs of the HIV and Aging and Long-Term and Lifetime Survivors Committee, is looking seriously at the problem of people transitioning from private insurance to Medicare who are living with HIV. And a targeted TA center that we need so that so that we can feel that we have someone who understands what our lives are like and what our meds are like. That transition for us is enormously shocking and difficult. Could the SHIP program be adapted to have at least a component that is designated exclusively for people living with HIV who are making this major transition from private insurance to Medicare? And if so, would it be an enormous cost or not? And would you need to collaborate with CMS in order to make that happen? That is a recommendation that our committee is very seriously looking at, but we need to know, we would love to have your feedback. Is that practicable? Could it be done?
So I can't answer on behalf of my colleagues at the Office for Health Insurance Counseling. I know, obviously, so HRSA's ACE-TA Center, which is sort of a specific technical assistance training center for Ryan White case managers, again, as I understand it, on Medicare and health insurance, is a good resource. Again, to my knowledge, it's not consumer facing the way that the SHIP is necessarily, but I think there's a way we could work together, maybe. In terms of something dedicated, again, I would need to take it back to the folks that run our SHIP program and see what they say. But I've worked with SHIPs in New York City and New York State, and in the city, because there is just such a high concentration of people living with HIV, sort of de facto, SHIP counselors just get to know the issues because they're seeing them a lot. So I think there's a lot to be learned from programs already, and it's just kind of maybe finding those best practices and lifting them up.
I don't see any additional placards. I'm going to turn to my co-facilitator to see if you have any comment.
In the interest of time, I will not make additional comments beyond saying thank you so much to Dr. Lee and to Andrea and also to Rita for your presentations today, and to all of our panelists for today. I think we all learned a lot. There's a lot of ongoing discussion to be had, but thank you for lifting up so many opportunities for collaboration, for shared learning, and also as we look at our path forward. We have a lot of work to do, and there's a lot of good work that's happened. So thank you all so much. And we will have slides, and so I hope that you all are open to follow up as members of PACHA. Look at those slides and all the rich data you shared and may have some follow-up questions. Thank you all.
Yes, thank you all.
Again, thanks to our panel facilitators who I think broke the world record of panel facilitated discussions around the PACHA table today. So Dr. Wheeler and Dafina Ward, thank you so much. I will now pivot to the next item on our agenda to close us out, or getting us closer to close out for the day, our public comment period. So I will turn it over to Carolyn Tallis.
Hi, thank you. Yes, we have a few folks online for public comment. To start off, each public commenter will have 3 minutes for their comment. First, we have Bernice DeRusso.
Yes, hi. Hello, everyone. Good afternoon. So my name is Bernice DeRosa, and I stand before you as an American HIV medicine certified infectious disease nurse practitioner, and also a proud board member of the Association of Nurses in AIDS Care, the Chesapeake chapter. So today I want to address a critical and urgent issue in our ongoing efforts to end the HIV epidemic. And that's an issue of under-prioritization that continues to affect Black women across their entire lifespan. So I just wanted to start off by saying that we will not end the HIV epidemic without truly committing to health equity and justice. And so despite these commendable strides that we've made towards HIV prevention and treatment, Black women continue to be disproportionately impacted at every stage of life, and across the entire HIV care and prevention continuum. According to the CDC, in 2019, Black women accounted for the majority of new HIV diagnoses among women, despite representing a smaller fraction of the population. So this is not just a statistic, but it's a clear indicator of systemic inequities that require immediate and focused action. It is essential to recognize that without intentionally including Black women in our policies, in our research, and not just as participants, but also in our funding agendas and leadership, that our strategies will continue to fall short. The lack of diversity and representation in our decision-making bodies is more than just a missed opportunity. It's a barrier to the very progress we aim to achieve. We need more voices that can authentically speak to the experiences and needs of Black women, voices that understand the nuanced barriers we face from stigma, misogynoir, and issues to access to healthcare. Furthermore, it's crucial to expand our perspective by including professional diversity, particularly by integrating more nurses who are often on the front lines of community health and understand patients' needs intimately. Our insights as nurses are invaluable to shaping practical, impactful public health strategies, especially to end the HIV epidemic. So to truly change the course of this epidemic, we must commit to equity and justice as our guiding principle. This means investing in community-specific interventions that address the unique challenges faced by Black women throughout our lives. It means building frameworks that not only prevent new infections, but also take a whole person, human-centered approach that no longer treats HIV and prevention as a separate issue that impacts some, but as a health issue that can impact us all, as seen with the I Am Possible HIV campaign. As we gather here today, I hope that we can all reaffirm our commitment to inclusive, comprehensive approach to ending the HIV epidemic, which is a commitment that recognizes the importance of every life and the human right to thrive and not just merely exist. Thank you so much.
Thank you so much. And next on our list, we have Nina Sublett.
Hi, thank you so much for having me today. My name is Nina Sublett, and I come to you today from the great state of Tennessee. Tennessee is known for a lot of wonderful things. Specifically, I'm from Memphis, Tennessee, which is located within Shelby County. Shelby County, Tennessee is one of the priority jurisdictions that have been identified in the End HIV Epidemic Initiative. Sometimes you think about that as a bad thing, that we've got a huge HIV problem in Shelby County, but the influx of federal help and dollars and resources was actually a very good thing for Shelby County, but it's not working. Since 2018, we've had a huge surge of new HIV cases in Shelby County, Tennessee. And then we've actually been hindered by our state leadership when the governor declined almost $9 million of funds that were earmarked for HIV testing prevention, and linkages to care. We have not only seen a huge surge in new HIV infections, we have also seen a surge in syphilis infections. Both of these things are affecting people of color and our teenagers. What do these things have in common? Mostly sex. And here we are in the South where we don't talk about sex and we don't talk about HIV. We're also dealing with stigma, HIV criminalization. We have the Tennessee Gateway Law that prohibits any kind of safe sex education. We're an abstinence-based program, but Tennesseans are scrappy, and we've rallied and we've worked together to find workarounds to help get through this process, but we still need help. And we come to you to look for ways that we can collaborate together and to ask our partners to help us in it's just this ongoing problem that we're having. And I'll throw in that we're also a state that also has declined Medicaid expansion.
Thank you very much, Nina. That concludes folks that pre-registered for public comment. For folks online or in the room, if you didn't give public comment but are interested, you could submit a written statement to Chloe Loving at PACHA@HHS.gov by emailing it by next Thursday, June 13th. Thank you.
And we have come to the closeout of our agenda for today. Vincent and I are set to make our closing remarks, but if there are others around the table who would like to offer their remarks or reflections on the day, we do have a couple of minutes for you to be able to do that. I just want to say it's been another impactful and engaging day for me in particular. I know that I was really struck at the start of our day with the conversation about what do the data say, both qualitative and quantitative, and really struck not by just the inequities that we've been echoing throughout the day that continue to persist, but really the growth and exacerbation in some communities and for some populations where the politics and the lack of enforcement in and around public health, good science, et cetera, continues to serve as barriers that get in the way. I know that there are tough decisions ahead, tactical redirects. I know we've talked about funding, given the reality of essentially flat funding in FY25 appropriations federally. We do hope that at least there's flat and not cuts, but it's dire straits. And I do hope that people are ready to provide some work, action, and education in our community about the hard work and the hard road in front of us. Lastly, I think I'll just say that I have a little bit of hope, and I think it was Francisco that helped start the day with that reality. The data also told us about all the successes and gains we've made in some areas. So I do know while we have these seemingly overwhelming barriers that persist, we have hope and we have the right leaders, I think, in the right seat for the right time. So with that, those are my closing remarks of the day. I'll turn it over to Vincent.
Thank you, Maureen. So I'll be brief with my comments. I'll simply say that thank you to everyone for being here today. It was a very full day, and so I feel the heaviness of all the information that we received. But there were a couple of things that stood out to me. One, this issue and this, what I would call a tension between plans and what's really happening on the ground and implementation. I think an ongoing theme has been issues around equity and really highlighting the inequities and thinking about new metrics. I think Dr. Sullivan gave us some ideas about ways that we can come up with new metrics for really evaluating our progress. I heard loud and clear this idea that we need to speed up, that while we've made progress, that we've got to move faster. And I heard, and it was sort of very profound public comment about Tennessee, the importance of policies and how policies need to be rooted in science and evidence, and that those things that are not, that are then implemented can really hinder what we are able to accomplish as a nation. I will end where Marlene ended and say that I too feel really optimistic and hopeful. And while I heard much that really resonates with the idea that we have made progress, I think what stood out for me the most was actually Dr. Cheever. I whispered to Marlene right after your presentation that I was so pleased because Ryan White is an exemplar of a focused effort. And you can see pretty dramatically individuals that are cared for within Ryan White and those that are not, and those stark differences. And what I also appreciated was, as you were presenting data, the attention to the subpopulations and not shying away from the inequities and aligning the interventions with those very groups that historically had been furthest from where it is that we want everyone to be. And so to me, that gives me hope. It means we can do it. We just got to figure out how to do it both inside and outside of Ryan White.
So with that, are there any other members, federal partners who have a closing comment before we wrap up for the day? Okay, seeing none, we will move right along. So we do want to ask folks to not run completely away. HIV.gov would like to organize a group photo for us today and day one. I also too want to thank those that gave public comment, by the way, and we do have another opportunity on tomorrow to open up. And so our beloved PACHA-to-the-People conversation is scheduled on our agenda for tomorrow. So those who are willing, please sign up for that session on HIV.gov. And again, to our wonderful, illustrious new executive director, Ms. Carolyn Talev, all of the staff at OIDP, and those who support PACHA in countless ways, the technical staff, the teams at Rosalie and Associates, HHS Studios. Thank you for all that you do. We are recessed until tomorrow morning, and join us for the photo. Thank you.
Produced by the U.S. Department of Health and Human Services.